Thank you very much, Dr. Tina, for the nice introduction. First of all, I would like to thank the organizers, the PSA, the CME for this invitation. I am truly honored. My lecture will complement the very nice lecture of Dr. Sherwin Payag, which was delivered last Friday, the December 2, in which he talked on morbid obesity on adults, particularly those with diabetes, hypertension, and OSA. I have nothing to disclose, and a lot of what will I say are actually from what I have learned in my 35 years of anesthesia experience and 30 years as a pediatric anesthesiologist. So ambulatory typically means ability to talk, to walk, but in the context of surgery, it refers to patients who are able to leave the hospital on the same day of the surgery. Ambulatory surgery can be called by other names: ambulatory, same-day surgery, outpatient surgery. And an ambulatory surgery or procedure is usually a procedure that can be performed relatively quickly, low risk, and requires a small incision. Now, the question is, why do we do surgery in an ambulatory setting? Isn't it much better to have all of these patients admitted? So let us go back to the core foundations of ambulatory centers. And these centers, they say, save, we have savings in terms of time and money. There's no need to be admitted, no deposits needed, done at the most convenient time for the patient and the practitioners. And the patient goes home after a short period of time. All of this, the foundations include safety, efficiency, convenience, ambulatory, and being cost effective. Now, these are just the standard criteria for surgical procedures to qualify as an ambulatory pediatric ambulatory care. And the pediatric ambulatory anesthesia care can be performed within the spatial constraints of the facility. There is no need for invasive monitoring, little or no chance for blood transfusion, minimal surgical complications, and the post-operative pain are manageable by oral regimens. There is a control of nausea and vomiting, and the post-discharge nursing must be simple. Now, there are procedures performed in an outpatient setting, the what we call the non-operating room anesthesia setting, and it would include both diagnostic and therapeutic procedures. Diagnostic like endoscopies, MRI, CT scans, and therapeutic, which includes intrathecal chemotherapy, linear acceleration, and the like. So these are the examples of surgeries in which can be done on an outpatient basis. It can range from ophthalmological procedures, strabismus, otorhinolaryngology like laryngotomies and tonsillectomies, especially in the first world countries, dental procedures, extraction and rehab, cast changes in orthopedic surgery. We have lots of procedures done by our pediatric surgeons, craniotomies, INDs, and excisions. In urology, which includes hypospadias, circumcision, and the like. So, ambulatory surgery in an obese, morbidly obese pediatric patient. So I would like to borrow the slide from the recent proceedings of the American Society of Anesthesiologists annual convention, which states that just because we have been doing a lot of cases of individuals without encountering any problems, it does not mean that we should be continuing the practice even in morbidly obese patients. Just because we can doesn't mean we should. Now, by chronological age, our pediatric patients are classified into this: pediatric, 18 years and younger, adolescent, pre-adolescent, child, toddler, babies, and neonates. So our special concern, those who have morbid obesity, are those in the adolescent and the pre-adolescent age groups. So what is obesity actually? Adult morbid obesity is defined as a BMI greater than or equal to 40 kilograms per meter square. And according to the American Pediatric Society, the section on obesity and surgery, adolescents who have a BMI greater than 35 have severe obesity. Now, the prevalence of severe obesity is actually increasing, and nearly 10% of adolescents, at least in America, have a BMI greater than 35. And another 5% of Americans have a BMI greater than 40. So, but the definition of childhood obesity is not as simple as getting the weight uh, per height square. BMI in children, to be clinically relevant, is measured in BMI percentile. So according to the Center for Disease Control, WHO, and other health groups, there are slight differences in which we classify obesity in children and adolescents and those of adults. So in adults, you just get BMI, while in children, you actually get the age and a specific percentile BMI. Therefore, in pediatric patients, overweight means they are in the 85th to 94th percentile BMI. Obese are those with greater than or equal to 95th percentile BMI, or a BMI 30 kilograms per meter square, whichever is lower. And severe obesity are those with 99th percentile BMI. In children, you use BMI for age, which is gender specific, and we use growth charts, just like in the growth chart shown in the slide. You will notice that the BMI changes grammatically with age in children as body fat changes with growth, and between girls and boys with maturity. So taken from the US data, obesity in children, at least in the US, is a very grave concern. It is actually a worldwide problem. Now, 17% of children, they say, have a BMI percentile of 95% or greater. And morbid obesity in children in the United States is seen in 4% of their children. Now, we see a lot of obese children here in the Philippines, although the exact numbers are not known. So this is just a table taken from the latest ASA, American Society of Anesthesiologists, on the current definition of classification of the physical status with listed examples. And if we take a look at the most recent ASA physical status classification, a patient with abnormal BMI is already considered as a patient with mild systemic disease. That's an ASA 2 classification. Whereas a morbidly obese pediatric patient with or without problems is an ASA 3 patient. So a morbidly obese pediatric patient is already a patient with severe systemic disease. And of course, you have to add to that they will have certainly comorbidities associated with being obese, like hypertension, diabetes, obstructive sleep apnea, and difficult airway, which are all classified as an ASA physical status 3. So from our textbooks like Smith, there are plenty of adverse effects of obesity in childhood. And these include the following: hypertension, dyslipidemia, common fractures, and endocrine problems like diabetes, insulin resistance. There would be varied gastrointestinal problems, formation of gallstones, respiratory problems like asthma, OSA, and the like. So obesity is actually associated with a number of physiologic disturbances of concern with anesthesiologists. And respiratory complications include an increased work of breathing, decreased chest wall compliance, a decrease in FRC, an airway closing capacity, hypoxemia due to pulmonary shunting, and a lot of your kids, obese kids, will have a Pickwickian syndrome. So there would be a conglomeration of symptoms like somnolence, cardiac enlargement, polycythemia, hypoxemia, and hypercapnia. So being a morbidly obese individual, a child, is a special concern to us anesthesiologists. Now, other physiologic considerations include a decreased cardiac reserve and abnormalities, which correlates with the degree of obesity. Increased preload and afterload, increased pulmonary artery pressures, elevated right and left ventricular work, and hypertension are seen in obese adolescents as well as in adults. There would be gastric manifestations of being morbidly obese, just like a large gastric volume and a low pH. So these individuals are prone to aspiration, the high incidence of reflux. These individuals are prone to aspiration, and the signs and symptoms of reflux can actually mimic asthma. And they have steatohepatitis, the formation of gallstones, and a lot of obesities are also related with mental retardation. So airway, as anesthesiologist, is always a concern. We have a patient that is potentially difficult to ventilate, removal of carbon dioxide, and or potentially difficult to oxygenate. Hence, you must position them properly in order to best manage your airway, especially if you want to put in an endotracheal tube or a supraglottic airway device. Obstructive sleep apnea is an independent risk factor for perioperative respiratory events. So in pediatric morbidly obese patients, a lot of your pediatric obese patients are actually OSA patients. And this is according to the studies done by On, Otey, and Kumar in different studies. And majority of your children with OSA are actually obese. And the prevalence and severity of your OSA increases with increased BMI seen in these studies. So in this time of pandemic, where it's difficult to see our patients beforehand, we tend to miss a lot of things when doing a teleconsult, especially in the physical examination part. So in spite of this limitation, we should, as much as possible, do a focused history and physical examination with emphasis on obesity-related diseases. And this would include hypertension, diabetes, your airway, and other problems. So we got this from a variety of sources, and as anesthesiologists, we will be concerned with a lot of things. So having a patent airway, the patient is asleep, is always a concern with mass ventilation, airway obstruction during induction and emergence. Now, there's actually no correlation between pediatric obesity with difficult direct laryngoscopy. But the difficulty lies during masked ventilation and airway obstruction during induction and emergence. This is according to Samuels and Mortensen. Now, pulmonary-wise, there would be higher incidence of oxygen desaturation as seen in the induction and emergence of your morbidly obese individuals with a decrease in FRC, a decrease in FIV sub 1, and an increased oxygen consumption in all your pediatric patients. And they also noted that pediatric obesity has poorly understood links with asthma. Now, according to Subramanian, in a paper that appeared in Anesthesia and Analgesia in 2016, in their development of a pediatric ambulatory anesthesia risk assessment tool for perioperative respiratory events, there are the risk factors mentioned prominently in this paper. And the risk factors is a young age group, less than 3 years old, an ASA physical status 2 or 3, and morbid obesity. So a lot of your respiratory events happen because you are morbidly obese. And other risk factors include pre-existing pulmonary disease and a surgery over a radiologic procedure. So your perioperative respiratory events in pediatrics increases the odds of hospital admission by 2.5. There is a increase 2 times more that when your patient's supposed to be an outpatient but becomes admitted, you would have a longer hospital admission. And the cost is high for unplanned admissions because it's going to cost you 30 times more, and there would be 58 times percent higher indirect cost among outpatients who eventually develop complications. So having a morbidly obese patient, how does it impact the foundations of an ambulatory setting? We mentioned that the foundations are safety, efficiency, cost effectiveness, and convenience. But having a morbidly obese patient, although there is a small percentage of the pediatric population undergoing surgery in an outpatient setting, surgery in an ambulatory setting in morbidly obese individuals is not as safe, not as efficient, not as cost effective, and it's no longer convenient when these patients develop problems. They have longer PACU stay and a lot of times admitted when complications arise. So let me go back to the original question. Is it safe to do ambulatory surgery for morbidly obese individuals? My answer is yes, but I have to qualify. They have some caveats. So there are several issues you have to address. These issues include the personnel, you, the healthcare worker, the facility that you are working, the length of the procedure. A circumcision will take only 30 minutes, but an MRI takes several hours, the professionals who actually take care of these children. And when do you say no? Is it a battle of money or safety? Now, in the Philippines, there will be distinctions in the classification of pediatric patients because practice-wise, sometimes an 18-year-old is being taken care of by our general surgeons and not your pediatric surgeons. So what is the correct cutoff for a pediatric patient? Is it 18 years, 6 years, 21 years? In the Philippines, there's a no distinction. Some of these people you will be working with will be surgeons inexperienced to handle a pediatric patient. Now, none all of you will be working with pediatric surgeons, and I'm sure that a lot of you, more of you will be working with generalists. Not everyone works or near an academic institution or maybe a children's hospital. And while you may be working with some children, you might not be comfortable in handling young and very big children. So there is another question of the level of training and familiarity. Now, in the Philippines, some patients are done in an ambulatory basis, but these patients are actually admitted in other hospitals, brought to you by an ambulance, and you're going to undergo a procedure, an ambulatory procedure, probably a NORA, MRI, CT scan, then sent back to the hospitals they came from. So we must consider the following. And our population, at least in the United States, here in the Philippines also, we are becoming more obese. And morbid obesity is one of the fastest growing subcategory of obesity in youth, especially in the first world countries and first world cities. Now, morbidly obese children are ASA 3. Now, I would like to emphasize they are therefore not healthy. And morbidly obese adolescents present the same comorbidities as obese adults, just like hypertension, diabetes, respiratory problems, and airway problems. Morbidly obese children and adolescents present unique management issues in addition to comorbidities. And this is where you need to make decisions as to the suitability of an outpatient procedure. Now, airway surgery in morbidly obese pediatric patients with severe sleep apnea is highly discouraged. And if this patient discouraged some more if this patient does not even have a sleep study. Now, ambulatory surgeries are done in more than half of ambulatory surgeries in the of more than half of the surgeries in the United States, and this percentage continues to increase. And it is interesting to note that the majority of pediatric surgeries are actually ambulatory. And another problem, children are becoming increasingly obese, and because they are the fastest growing subgroup of obesity in children and adolescents, more and more of your pediatric population are subjected to surgery. And general anesthesiologists perform majority of these procedures without special training in pediatric anesthesia. I am not saying it's wrong, but it is an observation. So we must also consider the importance of training and competencies. The literature has shown that pediatric subspecialty training reduces rates of perioperative respiratory complications, and the morbidly or severely obese pediatric patients do experience greater respiratory complications. And majority of these perioperative respiratory complications are generally managed by skilled provider. Yes, you know this already for adults. You need to start thinking about your pediatric patients, your childhood obesity is linked to many other comorbidities, hypertension, diabetes, heart disease, hyperlipidemia, asthma, and it increases the likelihood of perioperative respiratory complications in children and in adults. So you have to change your mindset. Stop assuming that a healthy pediatric obese patient is healthy. Realize which children should be evaluated with a BMI percentile and a straightforward BMI. Learn to recognize when the age of the child and degree of obesity is going to lead to complications or unanticipated escalation of care or transfer of a particular surgery and in a particular context. What increases the risk of perioperative respiratory events? And there are plenty. We are constantly pushing the envelope of ambulatory care, patient selection for obese adults. Procedures normally done in patients are being done in an outpatient. Over time, we have become familiar with the care of our obese patients, but literature has shown that super obese do present increased risk of perioperative complications. And the same issues present in adults are present in obese adolescents. While physiologically they are less, pre-adolescents are less like adults, baseline vital signs change with age and require both experience and familiarity to anticipate and avoid complications. Now, most of of our anesthesiologists will perform an inhalational induction on a child, obese or not, due to their age, based on their level of maturity. And this may not be the right choice for you because inhalation induction involves an excitatory phase where the patient's breathing becomes rapid, shallow, and obstruction increases. Additionally, patients can experience muscle rigidity and uncoordinated movement of arms and legs. And the movement and obstruction can be significant and lead to complications if not anticipated in management. Medical conditions such as GERD, diabetes, hypertension, phenoclysis, or maybe putting an IV line for anesthesia and emergency medications is more challenging. So determining the right dose of medicine, ensuring that you get enough oxygen and fair flow are other problems. So you have to answer these questions. Can I minimize the risk and handle these complications? The use of opioids, regional anesthesia. Can I perform an IV induction rather than inhalational? And if you don't have any IV access, this patient develops laryngospasm, will I be able to manage it safely? So there would be critical events in anesthesia for morbidly obese children, inhalation induction, IV placement. This all depends on your personal skill set. So if the child is obese and you want to avoid the struggle during inhalation induction, you have to put in an IV upfront. So you need airway adjuncts, and those medications should be appropriate. So know what surgeries are the most at risk, and taken from the article of Money. ENT procedures would show an increased risk by more than 1.5 more fold. So this risk is increased further if the child is cared for by a non-pediatric trained provider. So from obstructive OSA is an independent risk factor. From COTE, obesity is a risk factor related with OSA, and the majority of children with OSA are obese. I would just like to reiterate. And severely obese children undergoing tonsillectomy is independently associated with increased risk of perioperative complications. So you asked about snoring and apneic pauses in your pre-op evaluation. And if your BMI percentile is greater than 95, you assume that some degree of OSA is present. So management will be multimodal analgesia, use regional anesthesia over general, and as much as possible avoid or minimize the use of opioids. So when do you say no? How old is the child? Do you deal with this child a lot, with children a lot? Do you take care of children frequently at your centers? If you take care of young children infrequently, this may not be the best case for you, a morbidly obese child. Now, is your tonsil and adenoid patient, do they have a sleep study? And do you have any other risk factors? So the answer is different for everyone. That is why it's so difficult, because all of these depend on you, the practitioner, your center, your staff, as well as the age of the patient, what surgery they're having, and the other additional comorbidities. So we must remember that morbidly obese children are ASA3 patients. Get out of your mindset that this child is healthy. Definitely, they're not healthy. Morbidly obese adolescents present the same comorbids and challenges as morbidly obese adults. And morbidly obese children, pre-adolescents present unique management issues in addition to comorbidities. And this is where you need to make decisions to suitability. Airway surgery in morbidly obese pediatric patients with severe sleep apnea or in patients without sleep study should not be undertaken at all in an outpatient setting. And our population is becoming more obese, and morbid obesity is the fastest growing subcategory of obesity in the youth, and we will be handling a lot of more obese patients in the future. So thank you very much for your attention.